Hello guys and welcome back to Counter 10. My name is Ani and on today's episode we have another live Viva practice demonstration. Joining me today as our mock examiner is Celia, who's kindly offered up some of her time to give this practice Viva, and our candidate today is Derek. Now it goes without saying that we wish Derek all the best of luck in the upcoming Viva sitting, and he absolutely smashed today's Viva out of the park. As you guys know, the point of these videos is to help with both the non-technical and the technical skills that come with giving a Viva, and along with that, it helps to semi-replicate what you're going to experience on the day. You guys know the drill by now. Today we gave Derek 1 minute perusal followed by a 20-minute Viva station, in which we covered 4 topics in total and then gave some feedback at the end. I hope you guys enjoy listening to this episode, and again a big thank you to both Derek and Celia. And let's dive straight into it.
1, 2, 3, 4.
Hi guys, thank you for joining me. First of all, congratulations Derek on getting a Viva invite, and secondly, thank you for joining me to do this live Viva with Celia present. How are you feeling?
Yeah, good. Thanks, Arnie. And thanks for having me on.
No, that's okay. If it makes you feel any better, like we were saying before we started recording, we're also really nervous being the mock examiners giving you questions. So the feeling of nervousness is definitely mutual. So don't stress.
Good to know. We'll all be nervous together.
And thank you, Celia, for joining me. You are slowly climbing up the leaderboards as the highest number of appearances on this podcast, just behind Justin. So I've dragged you in to do another live Viva. Thank you so much.
No worries.
We're going to do this similar to how we did the last Viva with Nick. Celia's going to give you a 10-minute Viva and then throw you over to me, and I'll give you a 10-minute Viva. Instead of the real day, we'll have just a 1-minute perusal, in which time you will just get to think about the opening question. On the real day, you get 2 minutes of perusal time. And then when we switch over between Celia and I, we'll just go into straight away my Viva without any kind of perusal. Afterwards, we'll mainly aim on giving you some non-technical feedback and then some technical feedback. And overall, we're just hoping that the people listening get some of that non-technical skill from doing these live practice Viva demonstrations. Yeah, the content is important, but at this stage, hopefully people are just refining the way that they go about the Viva. So, do you have any questions about any of that, Derek?
No, happy.
Cool. So, Celia, when you're ready, we'll jump straight into it and she'll give you the opening question.
Perfect. So your opening question is, what is an isomer? Your time starts now.
Great.
Do you understand the question?
I do.
Yep. Can you tell me what is an isomer?
So an isomer is substances with the same chemical formula, but different structural arrangement. And they can be classified as either structural or stereoisomers.
Perfect. And can you tell me much more about structural isomers and stereoisomers and provide an example for each type?
Sure. So within your structural isomers, you've got your either static isomers or dynamic isomers. Within your static isomers, you've got your chain and position. So they're the ones with the same chemical skeletons or carbon skeleton, but have a different position of their functional group. So an example would be N-fluorine and isoflurane, which vary in position of the functional chloride ion. Within dynamic isomers, you've got things like midazolam and thiopentone, and they're structures that change in response to their chemical environment. Within your stereoisomers, did you want me to go in and classify those as well?
Sure.
Yep. So you've got
Or
your...
just a broad definition for stereoisomers.
So stereoisomers are... they've got the same... again, the same chemistry, but they are non-superimposable and mirror images of each other.
Okay. What kind of isomer is warfarin?
So warfarin is an enantiomer, which is a type of stereoisomer.
Okay, and which isomer of warfarin or which type of warfarin has the more potent anticoagulation activity?
I believe it's the S warfarin.
Okay, and why do they have such different potency?
So I believe it's due to, with the S and R type isomers, it's to do with the way the order in which their functional groups are arranged. And I believe the S isomer must have a stronger affinity to the vitamin K epoxide reductase, which is the mechanism of action.
Is it the functional group? Have you mentioned that it's a stereoisomer?
Sorry, I think it's just the way it interacts with the site of action.
Okay, and how does warfarin exert its anticoagulation effect?
So it's a vitamin K epoxide reductase inhibitor, which means that it inhibits the vitamin K dependent clotting factors, being 2, 7, 9, and 10,
Okay,
as well as protein CNS.
yeah, and why is there a procoagulant effect with warfarin?
So it's to do with the half-lives of protein C. So protein C has a lower half-life than the other clotting factors, and so you have an initial state of hypercoagulability.
Right. Can warfarin be given as a standard dose to all individuals, or why do individuals have different doses?
Sure. So I guess it will depend on an individual's number of clotting factors and amount of vitamin K, as well as liver function and protein binding. So because of that, it needs to be closely monitored with an INR.
Okay. Any other potential factors as to why there's different variable response to warfarin?
So the way it's metabolized as well and the way it's excreted, so liver and renal function. And it's also a drug that has many interactions with other medications. So things like CYP450 inducers or inhibitors can affect its effect.
And how is warfarin's activity monitored?
So it's monitored by either your proton time or your INR.
Yeah. And how can warfarin be reversed?
So there's a few different ways. You can either do a conservative approach, so just waiting until the warfarin washes out and your body accumulates or produces more of the clotting factors. You can also give vitamin K, or alternatively, you can also provide clotting factors directly in the form of FFP or Beriplex, which contains all the vitamin K dependent clotting factors.
Aside from warfarin, are there any other oral anticoagulants?
Yep. So you've got your direct acting oral anticoagulants. So ones that act directly on factor 10, factor 2. So they're things like your rivaroxaban, pixaban, and dabigatran.
And what are some advantages of these oral anticoagulants that you just mentioned over warfarin?
They've got a much more predictable pharmacokinetics, so don't require regular
I'm
monitoring.
going to move on to the next topic. What are the respiratory changes that occur in pregnancy?
Sure. So I can split that up into anatomical changes, changes to lung volume, mechanics, and gas exchange. In terms of anatomical changes, so because of the gravid uterus that compresses up onto the chest wall, you do have a reduction in your lung volumes and also laxity of your membranes through the action of relaxin. In terms of your minute ventilation, so that increases in pregnancy, secondary to an increase in both respiratory rate as well as tidal volume. And that's due to the action of progesterone. And that can roughly increase up to sort of 30 to 50%. In terms of gas exchange, so because of the compression of the gravid uterus, you do get basal atelectasis, a reduction in your FRC, and you can get your closing capacity above your FRC and a tendency for atelectasis. And then in terms of gas exchange, so you will get a low CO2, which means that you have a leftward shift of your oxygen hemoglobin dissociation curve, and therefore increased affinity for oxygen.
Do you know any changes that occur in the airway itself during pregnancy?
Yeah, so you do get airway swelling, secondary to, again, the actions of progesterone. You do get some bronchodilation as well. But yeah, that airway swelling is significant in terms of making direct laryngoscopy potentially more difficult.
Perfect. So in labor, you may see transient periods of desaturation. Can you explain why this may occur?
Yeah, so I think the main effect is due to the reduction in FRC, which means that you have a reduction in your oxygen store. Are you talking, sorry, about the time
In labor.
post? Oh, sorry, in
So in
labor.
labor, yeah. So you may see
Yeah.
transient periods of desaturation. What can
Yeah.
explain why this may occur?
Yeah, sure. So yeah, during labor, you've got a hypermetabolic state as well. So you've got increased oxygen demand and consumption. And similarly, like I said, you've got an decreased FRC, so decreased store and supply.
Perfect. And does anything change during in minute ventilation during labor?
I believe it increases.
Yeah. And what would that cause your PCO2 to do?
That will cause a decrease in your PaCO2.
Okay. Good. After the delivery of baby, when can you expect lung volumes to return to normal?
I think it's over a period of weeks.
Okay. So you obtain a arterial blood gas sample from a woman who's 36 weeks pregnant, otherwise uncomplicated pregnancy. Would you expect to see a change in arterial partial pressure of O2?
You do tend to get a slight increase, so I think it's roughly around 105 millimeters of mercury.
Perfect. And what about the arterial PCO2?
The PCO2 is low as well, so between 30 and 35 typically.
Okay. And what would be the expected pH from this blood gas sample?
So an alkalosis, so 7.45.
And is there any advantage to having a lower PCO2 and a higher PaO2 in pregnancy?
Yeah, it facilitates gas exchange between the placenta and the fetus.
Okay, perfect. And what is the partial pressure of O2 at the umbilical artery?
Umbilical artery is 18 millimeters of mercury.
Yeah, and what about the umbilical vein?
28 millimeters of mercury.
Okay, aside from the partial pressure gradient at the placenta, what else helps facilitate oxygen transfer at the placenta?
Sure. So I guess when talking about gas transfer, the factors determining that would be based on Fick's law. So that's your partial pressure gradient and your surface area, and inversely related to your thickness of the membrane, as well as the size of the molecule and the solubility. So specific for gas exchange at the placenta, you've got a higher concentration of hemoglobin in the placenta, as well as a different structure. So you've got your alpha and gamma subunits, which have a lower affinity for.
I'm going to pass you on to Ani now.
Yeah, sure.
Can you tell me what are the mechanisms that can produce nausea?
Sure. So I think of that in terms of the structure of how nausea and vomiting is controlled. And so you've got your inputs from your vestibular nucleus, which can cause nausea. And then you've also got inputs from your bloodstream, so toxins. And then you've got receptors in your gut, your serotonin receptors that can also stimulate nausea.
Okay, what is the chemoreceptive trigger zone?
So the chemoreceptor trigger zone is an area which sits outside the blood-brain barrier, within the lateral walls of the fourth ventricle, and they receive inputs from your nucleus tractus solitarius and monitor your blood, as well as receive inputs from your vestibular nucleus, and kind of acts as the playmaker essentially in terms of receiving all those inputs and then providing an input to the vomiting center and then controlling the vomiting reflex.
Okay. Do they get inputs from the nucleus actus solitarius? Are you sure about that?
Oh, I've seen it variably written in the text, but I think the nucleus tractus solitarius might feed directly into the vomiting center as opposed to through the chemoreceptor trigger zone.
Would the chemoreceptor trigger zone be an effective sensor if it was within the blood-brain barrier?
No, it wouldn't be, because it wouldn't be able to detect the toxins within the blood or the substances which wouldn't be able to cross the blood-brain barrier.
Yeah, good. What receptors are located in this zone?
So you've got your acetylcholine receptors, so muscarinic receptors.
Are you sure that there's muscarinic receptors in the chemoreceptor trigger zone?
Um, I know there's your dopamine, your serotonin, as well as your histamine, and I thought predominantly it was your muscarinic receptors within your chemoreceptor
What
trigger
type
zone.
of dopamine and serotonin receptors are there? Do you know the subtypes?
Yeah, there's your D2 and your 5-HT3.
Okay. And you said that these receptors relay information to the vomiting center. Where is the vomiting center?
That's within your, I think it's within your midbrain.
In your midbrain. Okay. Do you know any classes of drugs that work on dopamine receptors?
Yep. So you've got your dopamine receptor antagonist. So that's things like your droperidol and metoclopramide.
Okay. And what classes of drugs are these?
They're antiemetics or antidopaminergic agents.
Okay. You mentioned metoclopramide. Well, did you mention
Mhm.
metoclopramide? I think you did.
Yeah.
What is some of the side effects of metoclopramide?
So side effects would be you can get prolongation of your QT, and you can also get effects with your central dopaminergic pathways relating to your extrapyramidal symptoms. So you can get your things like akinesia, muscle atonia, and yeah,
Yeah. Is there any particular groups of people that you would avoid giving this drug to?
Parkinson's patients.
Any other group?
Not that I can think of at this point.
Right. Is there an alternative drug that you could give as a dopamine antagonist for, say, the Parkinson group patient?
Yes, there is. I believe you can give, is it domperidone, which just acts peripherally as opposed to centrally?
Okay, good. What's the normal dose you would give to prevent nausea and vomiting of metoclopramide in an adult?
So typically 10 milligrams IV, but my understanding is that the doses required to provide a useful effect in terms of the number needed to treat is actually quite high, but that's limited by the side effects. And you tend to get more of an effect when you're using it in combination with other antiemetics.
Okay, you mentioned the term number needed to treat. What is that term?
So it's the number of patients that needed to be, sorry, the number of patients that need to be given the medication for it to provide an effect.
Okay, and you said that it's high in metoclopramide. Would you know roughly what it is?
No idea, sorry.
Okay. How do you think it would compare to, say, giving 4 milligrams of IV ondansetron? Would the number needed to treat be higher or lower
I think it'd be higher,
for metoclopramide?
the metoclopramide, yeah.
Yeah, good. So if a person does start to vomit despite you giving these antiemetic drugs, what are the steps that occur for a person to vomit?
Sure. Sorry, can you repeat the question?
That's all right. We're going to stop and move on to the next question,
Okay.
which is, what does the term atelectasis mean?
So atelectasis means partial or complete collapse of pulmonary lung units.
Okay, what can cause atelectasis?
So significant for us would be anesthesia can cause atelectasis. Also any obstruction within the airways can also lead to atelectasis.
Does it have to be obstruction within the airways or can it be anything else?
Can also be extrinsic obstruction as well, or
Okay.
things like um, pneumoperitoneum or obesity.
Oh. Does atelectasis affect my functional residual capacity?
Yes. Let me have a think. Yeah, so you have a collapse of your lung unit, so I would expect that your FRC would decrease.
Okay, and what specific lung volume is it affecting?
It affects your expiratory reserve volume,
Are you sure about that?
or it might be your residual volume.
What is the residual volume?
So the residual volume is the volume that remains in the lung at the end of a forced, or not a forced expiration, but the end of full expiration.
Okay, and what is a normal residual volume in a healthy adult?
Typically 15 mils per kilo.
Okay, on induction of general anesthesia, what strategies could you use to help prevent atelectasis?
Sure. So I can provide a little bit of PEEP,
Yeah, any other strategies that you would do?
positioning the patient as well.
So how
So
would you position the patient?
I would have them slightly head up and therefore reduce the weight of their abdominal contents, compressing down onto the lung.
Is there any other strategies you could do?
Not that I can think of.
Okay, you mentioned PEEP. What is the term? What does the term PEEP mean?
So PEEP is your pulmonary end expiratory pressure.
Okay, and how does PEEP prevent atelectasis?
So it provides end expiratory pressure and therefore prevents airways from collapsing during expiration.
Okay, and you said it's the pulmonary end pressure. Is that right?
Probably not. um, I can't think of it at the moment.
That's okay. Say I forget to put PEEP on at the start of my case, and now
Yeah.
we're 4 hours into the operation. What would you expect my oxygen saturations to do during this time course?
So without any PEEP, under anesthesia, you'd expect a degree of atelectasis and therefore a degree of shunt. And with that shunt, depending on the size of it, you'd expect to have a decrease in your oxygen saturations.
Okay, what is a shunt?
So a shunt is blood that passes from the right to the left side of the heart without being oxygenated.
Hmm. And so, could I improve my oxygen saturations at that 4 hour mark by putting the person on 100% oxygen?
Depends on the size of the shunt. So that can be described by the iso shunt equation. And so if you've got a shunt fraction of, say, less than 30%, then increasing FiO2 can improve your oxygen saturations. But beyond that point, you start to get diminishing returns.
Yeah, okay. Well, say now that at the 4 hour mark, I decide to put 5 centimeters of water of PEEP on. Will this improve my oxygen?
It depends. You might need to do a recruitment maneuver, so a sustained increase in your pressures in order to reinflate those alveoli. But yeah, I would expect that it would increase your oxygen saturations by reducing the amount of atelectasis and therefore reducing the amount of shunt.
Okay, so you said you might need to do a recruitment maneuver. How
Mm.
does a recruitment maneuver differ from PEEP?
So recruitment maneuvers are typically giving a um, increasing your intrathoracic or increasing your pressures for up to sort of 10, 15 seconds or so. And that is sustained. Whereas PEEP is just kind of a smaller pressure that's exerted throughout the respiratory cycle.
And what kind of pressures am I delivering when I'm giving a recruitment maneuver?
Anywhere between, say, 30 and 50 centimeters of water.
And why is that different to PEEP to recruit alveoli?
Is it to do with the fact that you
We'll
just may
stop
need,
there.
yeah, phew,
You can
phew.
finish that train of thought, but we will stop there.
You just need a higher amount of pressure to inflate to reopen those closed alveoli initially.
Nice. Take a break, take a big breath in. That was a mammoth 20 minutes, and I think you did very well. So before we get into feedback, I'll just say that grossly, you did very well. And then I'll hand over back to Celia, and she can go through your first couple of Vivas.
Oh, great.
Thanks.
So for the isomer or warfarin fiber, you basically went through all the questions that I have written. Yeah, so you knew what an isomer is, and you gave appropriate definitions, and you like classified them before I even prompted you to, which is great, so that we like didn't really need to go over that question. Basically, knew warfarin. When I was asking about, I guess, why a different dose is needed for different patients, just due to like variability in drug response pharmacogenetics, like specifically with the vitamin K reductase, epoxy reductase, there's different variants in gene, making it some are more sensitive to warfarin. And CYP2C9, which metabolize warfarin. There's pharmacogenetic in that. And the one big thing is you mentioned all the other factors, but the other thing is diet. So diet can affect our warfarin activity. You knew how it's measured, and you knew all the reversals for warfarin, which is good, and you knew the other oral anticoagulants. Other advantages, which I'm sure you would have said if we weren't running out of time, would be it's you don't need daily monitoring, and they have direct reversal agents for both your direct common inhibitor and factor 10 inhibitors. Pregnancy Viva, you've given me all the respiratory changes in pregnancy. Right, yeah, the transient periods of desaturation, which you got right, was increased oxygen consumption during uterine contraction. And then you get hyperventilation during the painful contractions, which leads to hypocapnia, leading to a transient hyperventilatory period, which causes a brief desaturation of oxygen. I think after delivery of the baby, I was looking at powering ham. FRC returns to normal within 48 hours, and then tidal volume declines within 5 days. So it's relatively quickly that the changes return back to normal. ABV stuff you knew really well. You knew the numbers. And then at the transition to gas exchange to the placenta. I think you mentioned Fick's law, and I was specifically wanting like double bore effect. The fetal hemoglobin, there's increased blood flow to the uterus during pregnancy, and more of the blood flow, 85% of the blood flow goes to placenta. And then there's a relatively smaller blood flow in the fetus, so the ratio is higher in terms of blood flow on the maternal side compared to the fetal side. And then the following questions were trying to get you to explain the double bore effect and the double Haldane effect. And then it ends up being like comparing gas exchange at the placenta to like at the lungs, essentially. Yeah, that's really it. But you got through most of the Viva.
Cool, thanks. Yeah, I feel like I probably wasted my time talking about Fick's law and should have probably just went for the money and talked about the double bore and double Haldane effect.
That's okay, but you weren't wrong though. Like I think if you had a question that you weren't sure, going back to like first principle, like the Fick's law is probably like the best thing to say if you didn't know what to say at that time.
Yeah, I feel like Fick's law can kind of fall back on Fick's law for a lot of things, which is nice.
And I think the thing with the Viva is like if you don't know the specific answer to a question, I always go like going back to first principle, like what I do know, basic concepts, and then kind of build on from there, and you let the examiner ask you more.
Yeah, thanks.
Nice. I think that flows on probably to discussing some non-technical things that I think you did really well in those first two Vivas that Celia gave. How did you feel as you were kind of progressing to that Viva? What were your stress levels like during perusal time and then throughout?
I think, before starting, pretty stressed, but then hearing the question, and it was a Viva that I've done before. So, it was good during perusal, like that time to organise your thoughts. And I feel like you probably didn't need the full minute or the 2 minutes. But I think you kind of just use that time to relax and kind of think about the way the Viva might go. And then during the Viva, I think having sort of a strong definition to start with kind of helped. I wasn't really predicting it going down the warfarin pathway, but so I was a little bit stressed when it went down that route, but then it was okay.
Yeah, nice. I remember when you have the 2 minutes, I remember my Viva on the actual day was like my opening question. First station was, what is saturated vapor pressure? And I'm like, I don't need 2 minutes to think about that.
Yeah.
And so I just told myself I got my opening like sentence in like 10 seconds. And now I'm just gonna like think about other things, think about try to distract my mind because I've always found that I really struggled with trying to predict where the Viva went. And if I
Yeah.
didn't go in a way that I was going to leaning towards, it would start to impact my performance. And so something like what is an isomer? When we were preparing these Vivas, I messaged Celia and I also said I have a Viva on isomers. So you can see how common things do come up commonly. And when you look at the examiner report, what is an isomer got asked, I think 2 or 3 times as opening questions in 2025 one. And so they're not trying to trick you with any of this kind of stuff.
Yeah.
The meat of it, which Celia went through, you explained really well. And so from a non-technical perspective, I think there was a couple of things you did really well. You you asked early on, and I think whether you knew it or not, you had a mental clock in your head, or it felt like you had a mental clock in your head. Specifically, when Celia asked the second question of, "Can you give me examples of your um, stereoisomers?" and you were you were talking about different types of static and dynamic isomers, and then you said when you went into the stereoisomers, you were like, "Oh, do you want me to classify, or are you happy there?" Because you knew you were kind of seeing, okay, how far do I need to go? And then from then on, you kind of answered questions more succinctly and to the point. Because she said, just give me an example of a stereoisomer broadly. And you're like, oh, mirror image, 3D configuration changes, optical, so on and so forth. And you did that again with Warfarin. And then when I think you asked, when you were going down the pathway of answering questions, specifically when she said about why is there variability in patients with warfarin. In your head, I could see you going down, oh, is there PD reasons? Is there PK reasons? And you said like, oh, it must be liver function or renal function. And so you were using a really systematic way to answer from a non-technical perspective. And the key phrases I saw you use, which I think people always nitpicky about, and I think it's unfair, is when you answer something that you don't know, you say something like, I don't know, or I think, or something, but you use phrases like, I believe it is this. And that small change of words really does impact the way that we hear things on the other side. Because when you say, I think it is, leaves you open to further cross questioning. And so when you say something like I believe or you go with it and you knew all this stuff, so that's why I think that's a safer choice of words. In the second Viva, there was some really important stuff from a non-technical perspective and a technical perspective that kind of overlap. So the first thing was when you started talking about the broad kind of changes that happen with the respiratory system in pregnancy, you went through a lot of detail about different things, but you could see Celia went back and talked about airways. And so that took up a minute of your time going through that classification. So in that situation, it probably would have been better to then ask that in your head, or how do you want me to classify this? Should I give you the broad brushstrokes? And then we can go into the details because you obviously knew the details really well. And that came across when Celia asked you about, do you remember the numbers for ABGs and what to expect in umbilical artery, umbilical vein? Like obviously your clinical knowledge of recalling that rote learned stuff was really, really obvious to see. And the same thing happens, and this is an important thing to pick up from a non-technical perspective, is when she asks you an important question like what happens with labor, and you interpreted that initially wrong, and you ask for clarification, and you say something, an examiner asks you again in a different way, that's like a little light bulb moment that there's something that I'm not picking up here.
Mm.
And sometimes you just don't pick that up. I remember when I got a Viva on pregnancy as well on the day, and they were asking me about changes in the pulse that you feel in a pregnant lady, and that you get a kind of a wide pulse pressure, and what conditions cause a wide pulse pressure, and why does a pregnant person have a wide pulse pressure? And I'm like, I couldn't put the two things together, but they kept going back at it. And here you can see she kept asking it in a different way because she asked it in a way that, what do you think happens to ventilation during a contraction? And so then you should, it's hard if you don't know, but those are little things you go, okay, if they're pushing me on that, there's something that I'm not getting here.
Yeah.
And in that situation, if you're not getting it, you can just say like, oh, do you mind just um, clarifying exactly what you're asking. So that's okay to do because it might be a critical point that they want to get a pass mark on.
Yeah.
But I didn't think from that Viva, and Celia can correct me, that there was anything that you said that would fail because you went through all the factual knowledge and understanding really well. That might have been just the extra mark to make you from a 3 to a 4.
Yeah.
Is
Yeah,
that
no,
what
you
you felt
got
like,
everything.
Celia?
Yeah, I thought it was looking back, I'm like it's probably pretty mean for me to put that as the second question.
Mm.
But no, you got every like factual stuff correct. It was just kind of seeing how whether you can apply it to like
Yeah.
I guess real situations of what happens and why it happens kind of thing.
And so when we move on to my Vivas, which are really like two of the most meanest Vivas I could give anyone.
Cheers.
But I tried to make Vivas from the last exam. So I went through and looked at opening stems from the last exam. And so these were two questions that were asked in the last exam as opening stems. So it's unfair to ask you these as a second Viva because as opening stem, you would have had a minute to think about how you would classify mechanisms that produce nausea and how you would define atelectasis. And that's probably for the atelectasis part, you don't need a minute to think about how you would define it. But for the mechanisms for producing nausea, that is probably one where you do want a minute or two to get your thought. Jumping into that vibe is really hard. And I think I could see that when I first asked you, and you took a minute, or you took, when I say you took a minute, you took a second to think about it. And I could see once you took that second to pause and be like, oh, okay, I've got to mention drugs, infection, the GIT pathway. I could see you trying to remember that graph in your head or that diagram in your head.
Yeah,
And
that's
so when
exactly
I
what I was doing.
yeah, and so when I prompt you to say chemoreceptor trigger zone, it's not a fail mark because opening questions are never pass or fail. They're just ways to make you comfortable. And so you mentioned you were really good at laying down your heavy knowledge first and then answering the question. Like it's in the base, it's in the fourth ventricle, it's outside the, it's in the area postrema. And we had then the clinical reasoning, what would happen if this was inside the blood-brain barrier and you were quick to understand that my understanding that is that in the CTZ, it's mainly serotonin and dopamine rich.
Okay.
Within the vestibular nuclei, you have more of your muscarinic receptors. And within the vomiting
Okay.
centers, it's mainly your ACH receptors as well. And so,
Yeah, maybe I was thinking of the AC, the vomiting center. Sorry.
yeah.
Yeah, not the chemoreceptor trigger zone. Yeah.
And so the way you can target that is then use drugs such as dopamine receptors. And so when I was asking you to broadly classify, I was thinking about the classification of such things like phenothiazines,
Yeah.
benzamides. That's why I double asked. And because I was thinking about that, I couldn't remember whether you said metoclopramide, which is, it's the pressure that you feel on the other end as well, because you're trying to deliver a vibe at the same time as hear what the person's saying.
Yeah.
And so when we went to the side effects, you were good. So here, when you hear a drug and you think, okay, what are the things they really want me to get at? It kind of goes back to what Celia mentioned at the end. You're getting to the pointy end of your Viva when she asked you about the gas exchange in the placenta. You can just say you can kind of take stabs at what you think is going to be the most important thing. So metoclopramide, why wouldn't we give that dystonias? And that's probably the main reason, right? Is it just dystonic reactions and certain groups. Yeah, you can have other things. So particular groups that you might avoid it in would be Parkinson's and then people that have bowel obstructions because that increases gut transit time. So it might make a bowel obstruction worse if it's a obstructive thing rather than something that you're trying to improve the bowel obstruction, like an ileus or something like that, where you're trying to improve
Mm.
mobility. Um, your knowledge of domperidone was good. Your knowledge of the terms number needed to treat and the dose, I think the way you answered that was really good. And so just when you get into the end of this kind of vibe and you're getting asked questions like, what's number needed to treat? In your head, you can kind of be like, I think I've got through to a 3 here. Like, like
Okay.
we started off talking about nausea and you asked me number needed to treat. I think we've gone into clinical application in my head.
Yeah.
So you can take like a big sigh and be like, oh, yep. And again, you don't need to know the exact numbers, but you knew the broad principles. And these all come from like the fourth consensus PNV guidelines. So the number needed to treat for metoclopramide is variable. It's like between 10 to 20, and for ensitron, it's like 6 to 7. So that was good. And then we started talking about other stuff, which was a poorly worded question by me, but it was mainly to ask you, did you know the steps in vomiting? And so,
Yeah.
uh, and if you really got far, which like I made this vibe with too many questions, we would have then talked about the effects of prolonged vomiting. But
Yeah. Okay.
the fact that you got to number needed to treat really good because we're already kind of changing topics or talking
Yeah.
about things that are related.
Yeah.
The reason I picked what does the term atelectasis mean as a second viva is because I've never actually seen that as an opening stem. I thought it was quite an interesting opening stem.
Yeah.
And you answered it like textbook. If you type in atelectasis definition into Google, it'll spit out exactly what you said. It was like perfect. Um, and then the classification again threw you out because it's something that we don't think about. So you can think about it now when you're in a relaxed state as things that are affecting the intraluminal factors,
Mm.
extraluminal factors, or neural factors such as
Mm.
what's your sympathetic tone doing to cause atelectasis.
Yep.
And yes, it decreases your FRC and mainly through decreasing residual volume because it decreases the total amount of volume that's left at the end of your expiration. And then again, your factual knowledge came through really well. You knew what the residual volume was. And when we talked about how could you prevent atelectasis, this is again the clinical application question that comes in quite early. So we're hoping that you would say something like positioning,
Yep.
again, being prompted on it and why that's important. PEEP, but the high level thing is we can't really apply PEEP, so we apply an APL to give like continuous positive pressure, right?
Right.
Because it's on the induction what we're doing, but PEEP and ventilation strategies is right. And then the other things would be speed of induction. So the faster you can get a tube in, the lower time that they have when they're not breathing and the alveolus are collapsing.
Right. Yep.
And so then when we talk about PEEP and say we went into what happens if I don't put PEEP on for 4 hours, your deduction of understanding that it was atelectasis, but understanding why it was atelectasis was great. And I was asking you just extra questions because you were doing so well. Like, can you define shunt? And can you define these things? So you were doing really well. And again, we've moved topic now because now we're talking about shunt fractions. It's kind of similar, but we're asking about different things. We're
Mm.
talking about the ISO shunt diagrams, and you've already mentioned that you've given a very high level answer, say it depends on where my shunt fraction is, and you told me the number 30 to 35% of your ISO shunt. And then now we were just going into the higher level stuff, your understanding between PEEP and a recruitment maneuver. And so, really, as an additional point, what I was trying to get you to understand is that PEEP helps to prevent alveolar collapse. It doesn't help to recruit alveoli that are already collapsed because that
Yeah.
surface tension is too much.
Yeah.
So you need to drive a higher pressure to open that up. And so the way you do that is through a recruitment maneuver, which is a high inspiratory pressure that helps to overcome the surface tension and reopen alveoli. And you can only deliver it for a small amount of time because the next question would have been why does the saturations drop temporarily with the recruitment maneuver? Because it's
Mm.
essentially giving a high positive pressure, which is going to affect your venous return, your cardiac output, and it's going to change your west zones in your lungs as well because it's going to increase your alveolar pressure. So now you have more of a zone one creeping into where zone two is. So your zone one becomes huge as well. And initially, when alveolus open up, you might get some of that effect where you see with the salbutamol, when you give salbutamol to a really bad asthmatic, sometimes their saturations drop and then they get back up again because now you're getting that equalization of the VQ area initially.
Yeah.
So you might not get that so much with the recruitment maneuver because your blood flow is already there and you're just opening up the alveoli, but you might see that. But it's mainly probably driven by the changes in blood flow and the venous return going through the lungs. So again, that was all really like, I would say almost part two clinical knowledge stuff there in
Mhm.
terms of recruitment maneuver, but you did really well. And I might just hand back over to Celia and see if she had any non-technical things that she picked up while you were doing that second Viva.
I think the non-technical things that were good was when you didn't know a question, you were very quick to just be like, I'm not sure. So it moves that five along quicker. So you're not spending too much time trying to think of an answer, which may be wrong. But I thought you did overall really well in the two vibes that Anya gave you. I would not want either of those vibes on my day of. So well done.
Cool. Thank you.
Yeah, I think really well done. And I think you're still 3 weeks away from, I think 3 weeks away from the exam. And the way you're performing is amazing, both from a non-technical and a technical aspect. And even if you were stressed, it didn't come across to us as the examiners that you were stressed when you were thinking about that. So really good knowledge and delivery of the questions. And you should be really happy and confident in the way that you're going. And thank you very much for
Thanks,
doing this. I
guys.
know it's
Yeah.
very nerve-wracking.
Yeah, it was good motivation to do lots of vibers before this. So thanks for having me on, and thanks for all the feedback and the teaching.
Awesome. Well, thank you, Celia, also for joining me and being roped into, I think, your third guest appearance now on this podcast, and giving
Yeah,
an
I'm gonna try
awesome
to
vibe
beat
as well.
Justin's. I'm gonna try to
Yeah.
beat Justin's appearance.
Yeah, he might ask me to come back on. No, thanks,
Also, I'm
guys.
very sorry about my puppy.
No, it's all good. I have a tea ceremony going down at the on the bottom of my street, so well, there's probably some also noise interference from there. So thank you guys, and I just want to wish all the candidates the best of luck with their studying, and we'll catch you guys next time on Count to 10.